that social distancing due to COVID-19 was the catalyst, along with unprecedented policy changes. But is telehealth here to stay? Over the next hour, we will explore telehealth's impact on the US healthcare system and its future evolution. So without further ado, I wanted to introduce our speakers, starting with Mr. Girish Navani, CEO and co-founder of eClinicalWorks, the largest cloud EHR in the country, based right here in Boston. Girish needs no real introduction, being named to Boston Business Journal's Power 50 list and their 40 under 40 list, just to name 2 accolades. Next, going to Dr. Dhrumil Shah, CMIO and CIO of Compass Medical, a top provider group south of Boston. And as if CMIO is not enough, Dhrumil is also a practicing family physician who in addition consults for companies, exploring disruptive innovation and new business models. And lastly, we have Dr. Dave Prakash, digital care delivery and AI at a Fortune 50 benefits company. Dave's intellectual curiosity has taken him from medical school to the United States Air Force as test pilot to a flight surgeon, and now to a focus on healthcare transformation through AI. So I wanted to start off by getting a pulse from the audience. There's a small poll that Daria will be putting in the chat window. So if you could go there, and there are 3 questions. Did you use telehealth before COVID? Have you used telehealth post-COVID? So basically in the last 6 months. And what was your experience? Would love to just understand where folks are at, what they're thinking about telehealth. And if you could just click submit, that would be amazing. And while you're doing that, I'm hoping the results will just sort of pop up for everybody. Wanted to start off with the first question. So telehealth adoption has increased almost 200-fold since the pandemic started. Initially with patients avoiding the ER, afraid of contracting COVID, and then with provider offices shutting down for non-emergency visits. This required not only patients to change the way they sought care, but also providers to change the way that they operated. So what made this increase possible? What were the barriers before COVID, and do they not exist anymore? Or, you know, what's the deal? What's really leading to this large increase?
Good. Hi, everyone. I'm Dhruv Shah. I'd like to take a stab at that. The best way I can describe the pre-COVID state for telemedicine is it has been in a dormant phase for many years. And to be honest, technology was never a barrier. So I know this is an IIT AGNE panel, and most technologies would like to think that they had not mature technology or technology was not meeting the needs. Technology was never the barrier, in my opinion, for telehealth. I think the biggest thing in healthcare we talk about is from innovation or technology standpoint, is it going to improve the quality? Is it going to help my workflow? Am I going to get paid by using this technology? Is it going to increase my liability? And is it going to take more time or less time if I do it? And I think all the barriers combined, there is one barrier, which was the income barrier of reimbursement, which was lifted, especially in Massachusetts. Governor Charlie Baker, I believe, on March 15th, I remember that day vividly, as a nightmare from March 13th, to be honest, but March 15th is when the light of the hope came about for at least the state of Massachusetts, when the executive order was put in place, which mandated every single commercial payer and all the payers. CMS has already done that. They removed all the obstacles for reimbursement they could, at least on that day. And I think that's when the trigger for innovation happened. And the best way I can describe it, I think post-COVID, those barriers, some of those barriers have to come back, because you can't just open the floodgate and expect the innovation to create value. So there are going to be guardrails and framework refinement happening, but for the most part, the barrier of reimbursement, which was removed, which made physicians and practices open up innovation floodgate. They reached out to their existing technology partners, just like we did, and started to find how easy it is to implement technology. And to everyone's surprise, the industry which did not implement telehealth for 15 years did it in 2 weeks.
Mm-hmm.
I don't know if Girish, you have anything to add, but I think you saw the
No.
tremendous amount of growth nationally.
I think I'll call him Drew by first name. I know him both as a friend, as a user of the product. So no, I think it's been exponential. I mean, I think if you were to draw the curve, first 2 weeks of March or thereafter, just to put it into numbers, it went from, I'd say 50,000 minutes a month, which is almost nothing in January and February, to about 2 million visits a day, 2 million minutes a day. That translates to roughly 50 plus million minutes a month. That's more than an exponential increase. The examples that were given for why it increased are obvious. What's been surprising to some extent is that even though it's come down a little bit since May, it's staying relatively widely used. So why is that dynamics consistent now with an increase beyond its initial starting phase? I also think is the change has started becoming an acceptable paradigm. Patients are finding it convenient. Physicians are not finding it too disruptive. And there is payment reform that occurred where it's paying for the visit. I think it's the combination of technology, coordinated that with technology that is truly facilitating a differentiated experience, which is resulting in, I think, widespread adoption, continued widespread adoption is what I'd add to it. It's not just the initial phase of April and May. We've been subsequently studying it in June, July, and now August, and it seems to be holding ground quite well in terms of its usage. So those were some of the things I wanted to add, that there is a convenience factor that we've overcome. There's been a hurdle mentally that we've overcome. It's no different than e-commerce. I mean, I thought you'd only buy books on it. When Amazon was selling books, I never thought I'd buy a car online, and I bought a car online many years ago. So there are things that you do after you get used to it. I'd say telehealth has, in a way, impacted healthcare delivery in a positive manner. We are getting used to it. Now the innovation curve can accelerate its adoption in many, many different areas, which we'll hopefully get to talk a little bit further today, provided payment reform stays in place.
Hi, everyone. This is Dave Prakash, and I, of course, agree with Girish and Dhruv. I would add another perspective on this, and that's the fact that you're right. The technology, as Dhruv said, the technology has always been there, but the technology has never been implemented in healthcare. And anyone that's actually worked in or an entrepreneur in healthcare knows how hard it is to integrate new technology into the healthcare space. It's highly regulated, and there's barriers of entry here that are a function of who uses it, who pays for it, and who benefits from it are often three different entities. And so with that friction, it's really hard to get change. And on top of that, doctors are creatures of habit, and they don't have any time to actually change their workflow. I mean, when you think about it, 8 minutes a patient on time, oftentimes, and you're seeing up to 50 patients a day, how are you going to change what you do? And that reminds me of something that we used to say in the military, you're only prepared for your last war. And so doctors, or change never happens until there's a time of war. And then you change your tactics and develop new technology. And I think COVID, this experience right now is like war. And doctors who never had time to think about how can we improve our workflows, and EMR systems that were really, really billing systems more than actually patient medical documentation systems, weren't providing what we needed to increase efficiency and effectiveness. And it's only under COVID when suddenly we all have a chance to catch our breath. There's no patients to see in the clinic. And now you can rethink about how we can improve the system. And, when I talk to some of my subspecialty friends, they said, yeah, I'm not going to stay at 80% telemedicine, but going forward, I've realized there's 20% of my patients that I can actually see, cardiology, for example. If you've gotten an echo in the last year and you've got no changes in symptoms and there's no medication changes, you don't need to come in. Just give me 15 minutes on a video call and we're good. So, I think those are the dynamics there, but let's not forget the elephant in the room, reimbursement. If you're ever wondering why anything happens, follow the incentives or follow the money.
Yep, thank you. I think you guys all brought up really great points. I have a follow-up question, which is, we talked about how patients are now used to using telemedicine and providers have had opportunities to rethink the way that they do work because they had lower patient volume. But does that mean that it's as easy for providers to do virtual visits as it is in-person visits? And can we talk a little bit about the provider experience? And are technology companies thinking about that and how to sort of innovate like a hybrid model?
Who do you want to take?
Yeah, I think
I'd be happy to jump in on this one. So, you know, when I worked in the Air Force, one of the things that I did was I worked as an operational test pilot for B-52s. And having a position as a doctor as well, you know, I was able to fly the jet and look at things from a human performance, human machine interface perspective. And one of the things that one of my responsibilities was always, how do we make the system adapt to the person, the user? Because too often we start with technology and then we go look for, for a user that's willing to adapt to the existing technology. And so, you know, my philosophy on product development is always start with the user, understand what they need. You know, there's things like, well, human-centered design, there's, you know, you can do the ethnography and research. There's also things from the military that I did that I'm very keen to share, which is task analysis. You know, for a doctor, you know, before you go build a better system for the doctor, go understand when a doctor shows up in the morning to see their first patient, what are they thinking? What are the tasks that they're trying to accomplish when they first log in? And, you know, and that's going to be different than, say, what they're doing at, say, 6 o'clock, towards the end of the day. You know, are they looking at labs? You know, some doctors look at labs in the morning, some look in the evening, some prepare for their patients at the end of the day, some prepare, you know, in between each patient. Once you understand what the individual tasks that are, or intentions are of the doctor, then you can design a system that's meeting each one of those objectives. Because too often, you know, what I see with systems are, hey, this is great technology, let me just put it all here, let the doctor figure out how to do it. And no, you need to create a system that is anticipating what the doctor needs and delivers the right capability at the right time.
I'll try and now differentiate what I would call a bad experience and a good experience. If you said Zoom meeting or any other video meeting was telehealth, it's a bad experience. I can use the blunt experience saying it's a crappy experience because it will never really even come close to getting close enough to the face-to-face visit that you have in a physician's office. When you start thinking of telehealth visits that start with the first notification to the patient saying, please fill this thing out before the physician can see you. And that's in the context of that visit. Whether you're screening a patient for behavioral health problems. So let's just first pivot to saying not all physical exam oriented visits can happen in the telemedicine world long term. But there are enough visits that are happening today that can be very adequately supplemented and replaced with face-to-face visits. I'll put context to behavioral health counseling in that example. But starting a behavioral health counseling, you don't just open a Zoom call and start asking the patient, how are you feeling? You could really gear it towards the patient by putting together structured questionnaires that are clinical pathways before the visit starts and let the patient conveniently fill it out in their home setting. And then at the last step of that, the visit actually starts. And we have seen, because we've been studying case studies here in rigor, trying to understand the outcomes, it's going beyond convenience. It's going beyond COVID, that's the only thing I can offer. We're starting to hear real life stories from providers and patients that providers never saw patients in home settings, so they never really understood the social determinants of health. You did not really know what was being compromised after they left the clinic. That telehealth is giving them a better insight into the patient's home, and that some of these visits are actually complementing, if not even going further than an on-site visit. So that experience, and you combine that with what's happening now with wearables and home monitors, whether these are glucometers, sleep studies, activity trackers, blood pressure cuffs, you're now bringing some aspect of physical examination also at the point of care. There are many things that are going to converge together. It will never replace everything, but it will become a pretty compelling experience for many kinds of visits where it will actually supersede the on-site experience.
Yeah, and I think that these are great points. I think I would like to add to this that the original question around the post-COVID adoption and the patient needs. From my personal experience of doing telemedicine in two separate settings, I was a urgent care provider for last few years, well before I was a primary care physician, and now I'm back in primary care. One thing is pretty evident that in-person care and telehealth has to coexist together. And the way we see telehealth is enabling your actual in-person care. For example, like we physicians had to adapt on how to do the physical examination on an audio visit. One would argue that you can't do physical examination on an audio visit, which is actually not accurate. You can listen to the tone. The person's anxiety level is quite evident when you're talking to them on the phone. You can ask them to do self-examination, such as press on your sinuses next to the nose and see if it's tender. I can't see you, but you can tell me what happens when you press on it. Like, so we became creative as a end user. So to Dave's point, when the technology was given to us without workflow, maturity level, or the guidance or education around it, we still figured out how to be creative. So it tells us how creative this industry can be when the technology is designed to enable the care delivery. And I think what happened with COVID-19 is, like, I'll give you a fresh example. Recently, I did a telehealth appointment on a individual whose child was an emergency tech, so like EMT. So that child was able to do the abdominal pain examination on behalf of me, and I can see what he is doing. So you can literally do the examination through the surrogate members of the family. And the other thing is, when I saw the patient, when I see patients in the office now, I have at the least an N95 mask or a surgical mask or a face shield, and I'm missing out on the facial expressions, which I'm actually getting on a telehealth appointment. So there are counter arguments to telehealth and in-person. While I'm not able to touch the patient and do certain things on telehealth, because of COVID-19, now I'm actually seeing the patient in their comfort level in their home with their family member, and I can truly then assess their elements of physical examination, which I missed even when they were in the office. So I think they both have to coexist. As far as some of the comments I'm seeing is absolutely true. I think to Girish's point, we are now in the phase of what we call, I don't know if you guys are aware of the Gartner hype cycle. If you Google it, you will see that the trigger for innovation is irrelevant. Something is going to trigger the innovation. And this is what happened to us, that COVID-19 triggered the innovation when it comes to telehealth. Telehealth is not a new technology. It's been around for, one would argue, for 40 plus years, because the mentions of telehealth has been around for a long time, which many of us know as telephonic medicine, not telehealth. But I think what we are seeing now is more and more demand from the users, from the patients, from the payers regarding capturing data before and after the visit, enabling clinicians by having those questionnaires, as Girish mentioned, available to us. Maybe down the line, even having the ability where, just like during the Zoom meeting, I can share my screen and show the patient their, maybe we go over a CAT scan results together. Why not, right? Because this is what we did in person, that I would have a patient come in and say, let's look at the screen together, right? Because the EHR implementation, the way it was done, was the issue in the industry, not the technology itself. We did it for the wrong purpose and the wrong end user. And I think now that we are focused on user being the patient and the provider first, and then the payer, we ought to see a lot of good positive outcomes from the innovation itself within and outside the EHR, because all these technologies have to ultimately enable the user to provide better care. Because we have excuse in healthcare of complaining about all these administrative burdens and technology barriers. But at the end of the day, we still cannot go back to paper chart. Ask doctors all across the nation, and I think the studies have shown that 70% or more physicians would bluntly tell you that no matter what the problems are today, we don't want to go back to paper chart. That's done. Those days are gone. So I think the telehealth is going to go through similar hype cycle and the slope of enlightenment, as we call it, before we see the widespread adoption. We at our practice saw 70 to 80% of our visits were done in April and month of May via telehealth because we had to. But we still sustain, I think around 15 to 20% of the visits in the month of July. Why? Because we have so much overdue burden on in-person visit that now we are kind of shifting the paradigm that we did too much telehealth. Now we are doing too much in-person, but let's make sure before the next surge, if it ever comes in, we have a balanced way of doing at least 30-40% of our volume coming from telehealth. What is the right balance? I don't know. Kaiser Permanente is a system which is vertically integrated in West Coast. They do 60% of their encounters via telehealth because they are vertically integrated, so they don't have to worry about the copay and the workflows and some of the other barriers which we still have to in fee-for-service. But I don't see a way. I think we are going to figure out how to do this effectively in every market.
Great points.
Can I ask?
Go ahead.
Can I ask a question to the audience? Just a rhetorical question, building off of Dhruv's comment. How many times have you gone to see your doctor and had a medication change or, you know, a shoulder problem, and the doctor listened to your heart and lungs? My point is, there's a lot of things that we do in person that are clinically unnecessary, but it's a force of habit and it's a force of billing, quite honestly. You know, to be able to document that you listen to the heart and lungs lets you code a certain way. And so there are those habit patterns that, you know, have, I think, limited telehealth in the past. And I think we're seeing that a lot of medicine is about listening to the patient more than anything else. And I think as we appreciate that, things will get better. And one other obvious point I think it's important to make here, telehealth, too often people think of it as an audio video channel. And if that's all you're thinking, I think we're missing the point. Telehealth has to be so much more than that. It has to be an integrated platform, a system of systems, a cockpit, if you will, for the doctor to take care of the patient. Because if you just are duct taping a webcam on top of your EMR next to some other system, you know, you're just complicating the workflow and you're increasing the chance of error. So I just want to point out, I think the future of telehealth is integrating all of these tools into one system.
Great points. I totally agree. I can speak from personal experience with OB visits and going in and not needing to be there in person because you're just talking to them. So we've been speaking praises to technology and definitely the last couple comments and talking about how it really was sort of reimbursement issues or just sort of adoption issues or the fact that you know, we needed to learn how to do physical exams virtually, and it's possible if you ask the right questions. Girish brought up a point about remote patient monitoring, and you know, I would say that technology has adopted or has developed quite a bit in the last couple years, but adoption has been very low. Reimbursement's fragmented. Trying to integrate multiple different apps with multiple different remote monitoring systems and having providers, you know, understand, is it connected to your Apple phone or your, you know, Samsung Health app or whatnot, you know, are all complicating factors. So, you know, I think moving beyond urgent care and primary care with telehealth into more chronic disease management and, you know, a lot of the higher acuity visits sometimes requires this. What are your guys' thoughts on, is it different now? Have we evolved because people are thinking differently, or is technology still lacking in cases like this?
Are you referring specifically to RPM, remote patient monitoring devices and programs that support it? I think there is a Medicare program. CMS has a program now for their beneficiaries to be covered under RPM services, remote patient monitoring. Simply put, if a provider were to prescribe a home monitor to a patient, whether it was a glucometer or some other device, there's a reimbursement for the recommendation or a prescription to set that up. And then there is a reimbursement model if the provider were to look at 16 readings every month for a certain period of time. So there is definitely the financial barrier eliminated from the need to prescribe home monitors. Are all home monitors seamless to use? No, but have they evolved really, really fast in the last few years? Absolutely. There are devices that are today as easy as you turn the power button on as long as it's charged, will Bluetooth connect to your device and your PC and be able to give you readings. We call them trackers, broadly speaking. There are many now in the country that are evolving very fast. And I think that that's a very big role to play, especially in things like diabetes management. Glucometers are becoming quite reasonably easy to use. And they're also providing the information that's needed that doesn't require me to drive every day down to manage my results at a physician's office. So I think there'll be a widespread use of home monitors, including sleep studies. I'll give you a nice example for this. The normal way sleep studies are done is you may go to a clinic and lie on the clinic's bed in a dark room to study your sleep patterns. Very difficult to do, I would contend, if you're trying to understand how you sleep in that setting. But now think about a sleep monitor that goes under your regular bed sheet. And while you're sleeping in your bedroom, you get to understand your sleep patterns. And that can be then fed right in from a home monitoring standpoint for follow-up on telehealth if there are abnormal patterns. We've done this with cardio health before with Holters. You're seeing this happen pervasively with others. There is a significant curve of innovation occurring on home monitoring. There's a ton of money flowing into it as well. There's a lot of demand in terms of people focused in that space, and I think that will be the big place where the inflection point will occur in terms of telehealth and or any remote patient monitoring services, is the growth of devices that patients use at home.
Yep, no, I think that's absolutely a great point. I think, in fact, we are launching a remote patient monitoring program at my practice next week, which pretty much highlights some of what Girish mentioned. And interestingly enough, as I said before, the technology is, at least for the healthcare, has never been a barrier, at least in my opinion. Why? Today we have the technology to do 6-lead EKG at home. I have it at my own place. I have it in my hand. We have devices like TytoCare where you can do an ear examination, throat examination, lung, heart examination, and feed it to the telehealth platform and send it to your doctor. So all of those technology exist. It's how you implement it and how the business model and the operating model fits into the user interface, right? As Dave mentioned, I think it's all about the interface. I think all of this technology while they don't have to necessarily live into one platform, they have to create one interface. I think it's all about user design and user interface. That if I'm a physician and I'm looking at a technology, I always have a concept of what I call magic glass, that put a magic glass between me and the patient and take all the 70% of the task what I do today and automate it. We almost did a semi-failed pilot with IBM Watson a few years ago. And this is an example I've shared with Girish. Like, I think I was naive a few years ago when I got into the technology informatics, thinking that AI can change the world. I still believe AI can change the world, and it is doing it, but it was not mature enough. At that point, I believe 2013, the smartest AI IQ, which was a Google AI, was of a 6th grader. So I think we have come a long way with AI also, and I'm not the subject matter expert on it, but I think coming back to what Girish just mentioned, and I'd love to hear your thought, Dave, is the remote patient monitoring is a small component of telehealth. Telehealth broadly is changing the entire what we call virtual care model. I think in-person care is and need to become what we call comprehensivist model. There should not be any reason why a person needs to go and see a doctor or a provider for sinus infection, UTI, diabetes follow-up, where I need to review your glucose readings and change your medicine, educate you on something. If I don't need to touch you physically, you should not be in my office. I think that is how I operate now. Many physicians would disagree with me. But digital first is the model, because in-person care needs to be reserved for the sickest of the sickest, because we have people getting out of the hospital. At my practice, we launched a transition of care management program recently because we have 400 plus ER visits happening a week. We are not able to touch those patients. Our patients are going to the ER even though we never closed our office. And some of those ER visits don't belong in the ER. Majority of them we can provide safely in our urgent cares and primary cares or telehealth. Why? Hospitals would also appreciate that, because hospitals are struggling financially today because they are not getting the patients who really need to be admitted. Because guess what? The chronic disease patients are waiting at home. we are going to see more and more disease burden in next 6 months to 2 years because patients are canceling their elective procedures. Patients are afraid to go to the hospital. My own neighbors ask me before they go to the hospital, I said, like, what are you waiting for? You may have a fracture. Like, so it's very interesting to see that we are going through these dynamics of kind of debating about the in-person and the telehealth and what technology can and cannot do. I think the problem is more basic. Like, what problem are you trying to solve? Like, we can solve that problem from a logistics standpoint. I think it's all about the design. So I think it's all about design thinking and how you put it into workflow. And the best example is you are seeing right now, Livongo just got acquired by Teladoc for very reason I just mentioned. Like, we are seeing the future in this space. The largest and oldest telemedicine company, I believe, just acquired a majority stake in largest and oldest remote patient monitoring company.
Absolutely. I think time will tell
Drew,
if they're able to operationalize or not. Sorry, Dave, go ahead.
Drew, are you trying to tell me that the 40% reduction in MIs in this country is not because of a sudden improvement in people's diet and increased exercise in our society? So you're right. People are still getting sick, and it's not being captured. And I agree, RPM is a great opportunity there. But I'd like to bring it back to the end user. And doctors are definitely afraid of RPM because it's another long list of data points that a doctor has to review. Let me just give you an example. What it's like to be a doctor. Maybe you take a week off, and normally you have to check your patient's lab every time you order labs. It comes into your EMR system, and you have to click, is it normal? Oh, it was abnormal. I got to retest it, or I have to write a note explaining why I'm not going to do anything about it. When you take a week's vacation off, you come back, open up your system, you have 400 lab results you have to click through, and the 99% of them are normal. So now think about it like a glucose monitor. I think it's fantastic, but what happens when every day, or I'm getting spikes because every time that my patient had a cheesecake, and now I see, oh, the glucose was all the way up to 200. Or if the patient's taking prednisone, or corticosteroids for a rash, we know that that's going to increase your glucose naturally for while you're taking prednisone. And so if I'm going to get an alert every time for that, it's going to be really difficult, and I'm going to turn it off. We do that in the airplane all the time. We turn off alarms because it gets so annoying and we get used to it, and then planes crash. Think about on your phone, how many times you have Facebook popping up telling you, hey, look who liked your photo. It's distracting, and you actually want to just stop it sometimes. And so what I think about is, how do we get technology integrated into this process to solve this problem? So doctors, they don't need more streams of data. They don't need more data points. They need information that's aggregated, digested, and presented, so the doctor is given a decision point, meaning, all right, here's all of the different sources of data. Maybe it's their glucose monitor, maybe it's their activity monitor, maybe it's their medications that are all being integrated and then being presented to the doctor saying, hey, look, this is what's going, the glucose spike, but it's because of prednisone. Don't worry about it. It'll filter that out. But if it can tell you, hey, there is a spike, we think it is clinical, here's a decision point that only a doctor should make, then I think that would be Dr. Nirvana for me. When we get to a point where I'm not inundated with lab results, and I don't look at the EMR system with just this, soul-crushing weight of like, oh, look at all these labs I got to look at. So think about the doctor, and how do we get technology to automate a lot of the low-level tedium and low intellectual activity that a doctor does in the course of a day. Because I think a lot of the data coming from RPM is going to be low level. It's only when it spikes and it's integrated with other data points where it becomes clinically relevant, should it be presented to the doctor.
And that's a great point. Follow-up question is, where do you think that technology, that AI would live? So I don't know, for example, insulin titration. let's say we can automate that. Today, some pharmacists can do that. Obviously, a lot of specialized dietitians and endocrinologists do that. Sometimes primary care does that. But should it be in the EMR? Is it the telehealth company's responsibility? Is it, you know, physicians to come up with it on their own in their own practices? Curious people's thoughts on who sort of would house that technology.
So I'll take a stab at this, because I think the question you are asking is more two-part question. I think the collecting the data and turning it into insights, as Dave mentioned, I think that's a responsibility of the technology and analytics companies. As far as using those insights into creating an action plan is where the service industry has to evolve. So I think I would highly encourage every tech entrepreneurs to think of it as an end user in two buckets. I think one is the coach and the rest is your team. So use a football analogy. This is what I love to do the most is physicians up until now have been the quarterback. They need to become a coach. And I think the quarterback position is now going to be pretty much done by the rest of the clinical team. We have nurse practitioners, physician assistant, pharmacists, care manager, LPN, RN, MA. So the way we are doing this at Compass starting next September is select group of providers, limit the exposure so you can work out the kinks, select group of patients so you can understand what the patient feedback is. But then as Dave mentioned, the low intellectually low complex activities, which physicians don't need to be bothered by, needs to be done by the next tier clinician. So it's so not so much of a hierarchy model, it's more of the clinical appropriateness model, or the complex the care, you need the higher level of training and the experience. Right? So for someone to find a blood pressure pattern based on evidence-based guidelines, the technology is already mature enough to put anyone's blood pressure more than 160 or higher into a high bucket. And if someone suddenly checks a blood pressure at 2 o'clock in the morning for whatever reason, if it's more than 200, tell the patient to call 911 or the on-call service, right? Those kind of design clinical task or design aspects will have to be responsibility of the technology and a platform solution company, versus creating this service model where I may have a 24/7 on-call triage center where we have 24/7 nurses taking the calls from the patient, or managing a dashboard. As much as I would love to have a physician get a dashboard of all the alerts, I want a dashboard for my nurse also who's doing the after-hour triage. So they can then act on that 160 blood pressure at 8 p.m. and call the patient and avoid the ER visit rather than getting the ADT ping at 2 in the morning, or next day the patient ended up in the emergency room, right? So it's all about the event leading to a next event and where you build the intervention. So building the intervention is going to be a joint partnership between the service industry, which is healthcare, and all the other stakeholders involved, including payers. But I think the design models are, they need maturity, but they are definitely much more robust than they were a few years ago.
Dhruv, I love that football analogy. I wrote an article using that similar analogy, but I presented the fact that doctors are not only the quarterback, but they're also the left guard, the linebacker, and they're the water boy, the coach, and the groundskeeper. And you can't win the Super Bowl when your quarterback is playing all those roles. So to your point, it's right. Doctors should be doing what doctors do best. Mid-level providers should be doing what mid-level providers do best. And as we get more, I think actually technology is going to create new tiers of opportunity and careers. I think you're going to see digital health coaches and other, I don't want to use, we got to come up with a different name for it. We can't call it low-level providers, but I think you get the sense that there's going to be more opportunity, not less. So I don't think we need to take a Luddite view of the world that, technology is going to replace doctors. I think AI and telemedicine is going to give doctors their traditional role of being the educator and the counselor for patients and letting them do the things that are most appropriate for doctors to do. But talking about AI in particular, the technology is great, but I think that there's a lot of education that needs to happen for doctors. When I think about AI, There's a lot of automation and great things that are going to happen as we use nonlinear analytics on huge data sets, but there's enormous risk. And, I think a lot about bias. There's bias in the data. We know that doctors, typically when they see a woman and a man with equivalent chest pain, doctors are more likely to diagnose a cardiac event in the man and assume it's anxiety in the woman. And that's baked into the data. And, AI models are going to end up incorporating that and potentially propagating that. So that is one issue. And then the models themselves, we need to be careful what the proxies we use, with the features and characteristics that we're using, because one of my biggest concerns is this. Say we build a perfect model using perfect data and it predicts outcomes for cancer 100% correctly. The fact of the matter is, in today's society, if you are poor, you are going to do worse when you develop cancer, or if you develop cancer. Similarly, or on the opposite end of the spectrum, if you're wealthy and you develop cancer, you're going to do well on another round of chemo. So think about AI and, in the light of telemedicine, in a situation where it's telling the oncologist, hey, this patient should go to hospice. Well, because they're poor and or they're not going to do as well. That's a fact, but it's because they're poor. And this person, they're wealthy, social determinants being what they are, we think that they're going to do well on another round of chemotherapy. That's going to create a very dangerous dynamic, especially when you look at COVID. You think about the decreasing socioeconomic mobility in this country. You look at what's all around us right now, and COVID, with the education disruption, it's only increasing that disparity. So I'm really concerned about technology, and I think telemedicine is going to be, working very closely with AI. So one of the things that I talked about in a presentation I gave earlier this year at a small conference was this. Today when doctors meet, or in academic centers, you have what's called journal club. Hey, we're going to look at papers and review, the methodology behind this study and determine if it's a recommendation that you should follow or not, just so you make your own decision. I've proposed, I think we need journal club for AI for doctors. I think doctors need to become educated and have a toolkit that they can refer to when they look at systems and say, hey, you know what? What was the data that they used for this? Is it generalizable? What's the risk of bias? What are the issues with fairness? And so I think doctors need education. So I know I'm deviating a little bit, so forgive me, I'll stop. That's kind of my world with AI, but I'll stop there.
Okay, so Reena, I just want to do a time check. We have about 10 minutes, and I think it's been a really good discussion. I'll just give a quick update on the polls results, because I just realized maybe not everybody could see the poll results. So what we had is 85% said they had not used telehealth prior to COVID. 64% have since COVID. And what was the experience? Interesting. So 48% said the experience was positive. 21% said it was mixed. And we had about 9% said they did not have a very good experience. So, it's actually more positive than I expected. But the numbers for positive seem a little higher than I thought they would be. So that is good. And so I think with that, I do want Reena to give you and the speakers a chance to talk a little bit about the future barriers. We talked a little bit about what you all have seen now, but I think it's very important to talk about short term, a little bit longer term. What do you see? So I think we're not going to get a chance to answer, to address audience questions. I'm going to hand it over to you, Reena, and we will do our best to answer some of the audience questions offline. So over to you, Reena.
Sounds good. Thank you. Yeah, those results are really interesting. From my time at Amwell, the 85% pre-COVID looks about right. And I'm also very interested in the positive results. And I wonder if it's because patients are able to also use FaceTime and some of these other things, and not have to necessarily download a second app and all that, which is some of the changes that happened during COVID, but don't know. So to talk about future real quick. So would love to ask the panel, what is your prediction for healthcare in the next 10 years? We've talked a lot about, technology adoption has been catalyzed with COVID. It's here to stay. Provider workflows are changing. Patient adoption is changing. We're not saying bye to EMRs. We're not going back to charting. So is that the same for telehealth? And, are we going to live in this AI world in 10 years, or is it going to be super slow and it's going to take 20 years? Would love to hear everyone's thoughts.
I'd like to give it to Girish.
Thanks. I think healthcare moves slowly. I think that's the first comment we'll make. And the reason it moves slowly is because it's generally a risk-averse culture for right reasons. It affects human life. So you may do things in other industries a little bit faster because the regulatory umbrella is not as tight. That's the first and foremost. So 10 years in healthcare may look like a long time in elapsed time, but it may be that it takes some backseat discussions around patient safety and also ethics of care before it becomes more widespread adoption with no thought process. Having put that in the forefront, I do think there is enough evidence collected in this pandemic, because what it has done is accelerated certain things that were inevitable. I think it's not just for healthcare. As you get to see changes occurring, whether it's certain trends that were going to take 10 years to occur, suddenly within 10 weeks have had an exponential change in that curve. What we've seen in healthcare is that there is a cost reduction component as well for telehealth and or remote patient monitoring. The example I will use here is that we often may not correlate to it in this conversation and on this panel, but we get to see in a segment of our population the underserved communities in the United States, where care is not easily available, accessible, or worse yet, there is no transportation for the patient because it's too expensive to drive to a physician's place. Taking an Uber or a Lyft is not the only, they can't afford it. They miss out on care because there was no access to transport. There is a significant population that falls into that bracket. I think technology will enable wider use of care, minor access to care. I use my words again. So there'll be much wider access to care. It will also be available at different times of the day. It will be available on weekends and weekdays. Technology will bridge the national lines of care delivery. Today, it is not uncommon for those of us, and all of us probably on this call, or many of us from Indian origin, for second opinions to be sent to us on WhatsApp, for which we try to find a specialist. Here, I've had a laptop physically taken to an oncologist with the results on it, saying, could you please tell me what the outcome for this needs to be? I see a world where telehealth for India will basically be accessible to a US oncologist by a cash model of reimbursement through these services. So there's going to be a national barrier broken because care delivery will transcend that. I think employers will take a bigger role in reimbursing for these services. Hence, the payer model will have to follow what the employer-backed plans will support, because there's a convenience and a productivity aspect to employees working. And the final point I'll make is the ethics of data. I think Dave referred to it, Drew referred to it. The problem with AI is that there is an inherent bias to data. Beyond bias, there is a problem with marketing and market motives to financially convert that data for targeting certain users. It's okay for a golf club ad to show up on my YouTube channel because I was looking for it. It's a whole lot different for a glucometer to be pushed to me if I looked up diabetes care. And I think that ethical boundary will have to be regulated. It's already difficult in social media to try and prevent targeting of individuals around news. It will be harder in healthcare not to have the older population that may be susceptible to this targeting to make bad decisions. So therein lies the dilemma in healthcare, that you can't make decisions that you could do in e-commerce as easily. This will all have to be woven, but this is an irreversible curve. The trend has happened. It is not, the genie has left. It is not going back into the bottle. Whether it's remote patient, whether it's telemedicine, whether it's excessive use of data for decision-making, Whether it's EHR companies doing it or any company that has money and intellectual capital, there is innovation that's coming in healthcare. And it's coming at a very fast pace because the basic platform of digitization happened, which is the physician's office. The next leg of the patient's home is going to be digitized in a very short period of time. So that's how I'll conclude what the future may hold for healthcare.
Nice. Dave, you want to go next?
Sorry. Thanks, Dhruv. I'll just be short here. Yeah, I think healthcare is a different industry, and move fast and break things is not appropriate for what we do in medicine. So, I think it's important. Sorry, I'm having some network issues here suddenly. But all I would say is, I think we need to focus on moving fast and fixing things. We need to be, the lack of regulation in this space should not be a opportunity for first movers to exploit it. We saw what happened in the tech world, here in Silicon Valley, and what that's done to the world. There's a lot of unintended consequences. So I would hope that the first movers here are a little hesitant and humble about what they can and cannot do with technology in healthcare.
No, I think that's an excellent point. And I think there's a reason why I think I asked Girish to go first, because I always like his outlook about the future. And I think there is, I don't have anything to add, except I would like to share something which recently inspired me. I think if you look at a podcast with a title called Healthcare Has Left the Building. And I think that's an excellent podcast from a VC from out of Silicon Valley, A16Z. I highly suggest everyone to at least spend 15-20 minutes and look at it. I think that's the outlook for me for next 10-20 years. I think I agree that healthcare is not going to move very fast. But if you ask me, we were not moving fast before and something happened, COVID. And I don't think we are going back to the previous state. So healthcare is going to struggle, in my opinion, for next 6 months to 2 years minimum to find the new normal. And after that 2 year, we will likely see some of the inherent changes where the due diligence for startup to get into the healthcare acquisition is not going to be 6 to 19 months. It may be still be not 3 to 9 months, but it's not going to be 6 to 19 months life cycle, which it was today before COVID. And same thing is going to be demanded of us in our job. Like my boss, my CEO knows that we implemented telemedicine in less than 3 weeks. So next time I go with a project and a budget and a resource and proposal, he or she is going to tell me, nah, Dhruv, you did it in 3 weeks. I think you can do this with less. So do more with less is definitely becoming the business new normal in healthcare, because we have a solvency issue. I think in healthcare across the nation, we are going to see massive amount of merger and acquisition at a smaller scale, because many of the independent practices are struggling today to stay solvent. I think we are fortunate to be in Massachusetts, where we have some of these advances in research and regulatory space. But I think Girish probably can speak for both, because most of his practices reach out to him and his team all the time. I think these practices need innovation very fast. Their decision cycle is a matter of days and weeks, not like months like larger enterprises. So I think the smaller practices, boots on ground, are going to innovate very fast. They are going to challenge the status quo of the healthcare before the larger enterprises even know. And I think the example of the reason I gave Teladoc and Livongo, I see that merger as not as an innovation. I see that as an essential way for them to survive, because the oldest and the largest companies are going to have the longest time to innovate. And the M&A is going to happen in that space as it should. But I think we're going to see a lot of new innovation happening from ground up. Where, like, just to leave you guys with a thought, I think, Irina, the question you asked about the insulin, there is a company called Mellitus Health. I just use as an example. They have an FDA-approved insulin algorithm, which takes the evidence-based guidelines and puts it into a simple formula which practices can use. The reason I mentioned that is Imagine that type of innovation being integrated with your EHR on top of the telehealth, where now remote patient monitoring readings not only create a custom alert, but now that algorithm will say, based on evidence-based guidelines, this is what the recommendations are. So I think that truly the AI, in my opinion, is not artificial intelligence, is the augmented intelligence. We humans are much more smarter than any technology we have created. And I think we need more help from the technology to take the mundane work out of the equation for day-to-day life, because we can elevate all of us to a higher level of enlightenment and efficiency, where the interactions are more richer, outcomes are more positive, and experience is more satisfactory. And I think this is the future we are going to see in next 10, 20 years. I think 10 years is going to pass by very fast in healthcare, unfortunately.
Okay, thank you very much. We're just on the hour. Actually, I feel like we just scratched the surface on so many topics. And a huge thanks on behalf of IIT AGNE to all four of y'all for joining in. You actually have given us so many ideas for future panels. I was like seriously taking notes down about, okay, we have to do this panel, we have to do this stuff. And so I think this is going to be something we, the engineering organization, technology, entrepreneurship organization is really looking forward to working with the healthcare. Girish has already been doing that for quite a few years, but we hope to engage that and continue these discussions on an ongoing series. So thanks to all of you once again, Girish, Drew, Mel, Dave, Reena. On behalf of IIT AGNE, thanks to all the participants, all the audience members. And we will try and cull through some of the questions, and I'll reach out to the speakers if they have a chance to answer some of the questions. And we will post that out over email. So with that, I'm going to end the meeting. Thank you.
Thank you. Good night.
Thanks.
Thank you all.
Bye, Drew.
Take care, dears. Bye-bye. Thanks, Dave.
Bye. Thanks,
Yeah.
everyone.
Bye-bye.
Bye-bye.